Hi, everybody.
Hey guys, Rachel, how are you?
Great. How are you?
Doing okay. I'm gonna turn my robot face off there. Good morning. I'm glad you wore a baseball cap too. It's Sunday casual.
I decided that Sunday casual meant that I could wear a sloppy bun and a sleeveless shirt.
You look, where's your drink? That's the question.
I mean, I don't
He's
really
already drank it.
know.
What's up, Tom?
Thanks. How are you, man?
Good. Hey, Marty.
Good.
See Michelle. Who was that?
It's Bang.
Thanks.
Oh, hey Bang, how are you?
Hey, Michelle. Nice to meet you.
Dr. Cared in the house.
Hi, Michelle.
You were front and center the other night, Michelle. You were awesome on the annual meeting.
Yes.
That's a lot of
You were
pressure,
it.
huh?
Thanks, you guys. That was so, it was way more nerve-wracking than, than like being on stage. Because I
You
thought,
did great. You did great.
I'm glad.
I
hope
thought it
you
came
guys
off great.
enjoyed it.
Yeah, we thought it was great.
Oh, great. Thank you. Marty, we're going to miss you on the board.
I was just starting to get good at it too, you know? They kicked me off.
Josh, I'm letting people in. You gave me power and I'm using it. Abusing
Please.
it.
That's good because I'm doing all the rest in the background, so that'll help. Thank you.
Cool. I'm going to sit here and abuse my power for a little bit. Anyone we don't want to let in?
Well, Marty's already in, so I guess we got to leave him.
Damn it.
All right.
Hi, Wade.
Hi, how are you guys?
There's Wade.
Good.
How's it going?
Wade was waiting. That's when I started letting people in.
There we go.
I thought he deserved to be let in.
Thank you.
No problem. I got to be useful some way.
Are things getting a little more relaxed in LA now, Rachel?
Work-wise, it's pretty relaxed. Like we can basically do whatever elective cases. Clinics are still socially distanced, but can't really do anything after work.
Right. New Jersey, we just started doing urgent cases only, nothing that needs an admission, and not many people are interested right now anyway.
Yeah.
That's where we are too, saying nobody's interested.
Yeah.
Our volumes are way down. Nobody's interested. They don't want to come in.
Yeah.
But we're allowed to do whatever we want.
Do you have a pet bird, Rachel?
No, I was just going to ask who's outside.
It's probably me just, here. I've got the window open. Gorgeous day here
Oh.
in the mid-Atlantic.
Very nice.
Yeah.
Yeah, I was talking to my parents in Jersey. They said it was gorgeous this weekend.
Yesterday was amazing. Today was a little cooler. Rained a little bit in the afternoon. You could still hang out outside.
Yeah. Yesterday was perfect though.
Yeah, it was.
Yeah. Really nice.
You living in Wilmington, Wade?
Yeah. Live right here,
Yeah.
right there in Greenville, really close to the hospital. It's great.
Nice. That's great.
Yeah.
Michelle, you look so smiley and happy.
Thanks, good. I'm just agreeing with everybody. We're doing the same kind of work. We have a few more people that are interested in coming in for surgery because they've been sitting in quarantine for almost 8 weeks. So they're ready to get their surgeries so they can go back to school. Fingers crossed to go back to school in the fall. So
Yeah.
we're getting started a little bit, but not the same.
Let's see.
Yeah, we're probably about running between 40 and 50% of people deciding not to come in. But we still probably at least half of the folks that we're offering to are offering to come back in. So we'll see.
So I'm
Yeah,
assuming
you're-
all of you have done this, but it is easier if you have your PowerPoint open in the background when you hit your share screen to hit your PowerPoint as opposed to hitting your desktop. It just makes it a little easier.
What does that mean, Josh? I know you wrote that. I don't know what that means.
Just open your talk. Well, you've done it now 5 weeks in a row, so you
I'm doing it the right way then.
yeah, you're fine.
All right.
If you I mean, to answer your question, if you minimize the PowerPoint when you go to share your desktop, it gets trickier. It's easy if you just have your PowerPoint open, and then when you share your screen, you just click PowerPoint and it brings you right into your PowerPoint.
So if it's open, I just click share screen and it'll show up. It'll be there.
Well, it'll give you options on what to click, and your PowerPoint will be one of your options.
Okay. Yes, you'll find out if I know how to do it.
I have faith in you, Rach.
Thanks. I appreciate it.
Wait, are you guys doing CT surgery? Is that picking up again, or is that kind of the last group that wants to come in?
Yeah, so that's kind of, the idiopathic stuff I think is probably up around 70 or 80%, but the CP stuff is what I was talking about, around 40 to 50%. We've had a pretty restrictive visitor policy too, with only one family member at a time. They wouldn't even let that person trade out, actually.
Yeah,
So,
same.
yeah, and so, so as we start doing like our spines and our semmels with rehab, that's a problem. That's a bit of a problem. So we've had several families tell us they didn't want to do that. They just now passed on a Friday that the parents can swap out every 5 days.
Okay.
So I think we'll be able to probably get some kids on the rehab floor now.
Now, you guys don't have a hot ER, right? That you have COVID patients in the hospital?
Yeah, I think there's 2 currently in the hospital, and I think we've tested both at the hospital as well as all our outpatient stuff. Somewhere around, we've had about 30 or 40 positive patients. Not been a ton.
Yeah, that's good.
All right, so I want to welcome everyone to tonight's pediatric orthopedic webinar. Those of you that are joining us from hand, we finished a few minutes early, so that worked out well. Tonight's topic will be on pediatric hip conditions. As everyone knows, we will continue these weekly, at least through the month of May, and next week we will also have expert, world-renowned faculty on scoliosis, and then we'll move on to a pediatric and adolescent back pain at the end of May. The hand lectures, as you know, we just finished the adult distal radius one. Next week will be carpal instability, and the following week will be carpal fractures and dislocations, and hopefully everyone has the websites by now. So tonight's faculty is nationally recognized experts on topics pertaining to the hip. We're going to begin just talking about the anatomy and physical examination of pediatric hip with Marty Herman from Drexel St. Christopher's Hospital for Children. We'll then go on to the imaging of the hip from Tom McPartlin out of New Jersey. And then we'll have Rachel Goldstein from LA talk to us about DDH. And then we're going to learn about the neuromuscular hip and coxavara and valga from Wade Schrader. We'll then move to Michigan, where Michelle Card will talk to us about Perthes disease. And we'll finish our evening up with Beng Yen up at Boston Children's to talk to us about SCIFI. So again, these are the websites in case you need them for the hand and upper extremity ones, as well as these pediatric orthopedic ones. And I'm going to turn things over to Marty.
You guys see that, Josh?
Yep, you're good to go.
Welcome everyone. I saw your names on the list popping up. So once again, enjoying being part of this whole thing. I'm going to off this night with the basics: pediatric and adolescent hip exam. We'll look at the concept of the chief complaints and how important it is, especially for evaluating children's problems. We'll talk about how to get a good history and then focus on some exam pearls. As you can imagine, this is a fairly topic in general. So as you're going through tonight's webinar, I really want you to focus on a couple takeaway points, especially on the most important topics, and try not to get too much or too lost in the weeds here. The chief complaint. I feel like when I'm evaluating kids in a clinic, and this doesn't just stand for the hip, This stands for anything that we're dealing with in pediatrics. Really get to the chief complaint. I know at times written by the MA and we kind of ignore it, but it really is an important part, especially when you're evaluating kids with a limp or kids with a painful hip. Like to have families describe to me in detail, or even show me sometimes what it looks like that they're concerned about. I'd like to know when they first know what is their concern. Sometimes it's the pain or the way they walk. Sometimes it's just that they don't like the way it looks. And then something that a very smart pediatric orthopedist, Dean McEwen, once taught me was ask about who is the person concerned. And this is focused mostly when you're talking the rotational problems like in-toeing or out-toeing or torsion. Because when you're talking about these problems to families and trying to reassure them, to reassure the person that has the concern as much as you have to reassure the mom and the dad. So I like to think of it in the sense that the different diagnosis really helps you guide your evaluation. And before I even start, I kind of lump these kids into 3 or sometimes 4 broad categories: the traumatic, the developmental, and the infectious categories. And they help you guide not only your history, but your physical exam, and then your diagnosticating and other studies as well. So right away, after the chief complaint, start thinking about these diagnoses. And here's how you're going to question them. If it's traumatic, it's the basics. You're going to talk about mechanism and onset and how much pain they have and what you do to relieve the pain, what the weight-bearing status is, and all these details that guide you when you're thinking that it's purely just a traumatic injury. The developmental ones are broad, and that can be anything from femoral eversion to Perthes disease to Skiffy. So think about what needs to be considered in that group, and that's where the perinatal history probably comes in. You'd like to know when they first noticed it or what made them notice it. Painful versus painless is very helpful in that group. And then, as I alluded to with the chief complaint, what is the gait disturbance and what is the range of motion or limits they have? And finally, remember that hip disease, sometimes, especially in younger children, is a big infectious problem. In other words, a septic arthritis or an osteomyelitis, and it may not be the very first thing that you think about. So as soon as you get into the weeds about what they have, start asking about questions that might lead you down that path. I'm an orthopedic surgeon. I will admit I only ask a couple of things on the history other than what I talked about. I do ask about the growth charts, and sometimes I'll ask about BMI. I like to know milestones. But I often will just say to them, tell me what you have in the family. Here's an example of a family that walked in and the father didn't even know what his disease was, but he knew it was related to the fact that he was tall and had a heart murmur. So he had Marfan's disease. Think about these things when you're going through the history. And then everybody should understand how to do a basic developmental history in a child and what the milestones are and when they should be achieved. So the exam is where we'll focus now. So it has several parts. You're going to do an observational gait analysis, you're going to do a exam, and then you're going to do some provocative tests. So I want you to think through these and have in your head a prescribed way that you're going to take care of every physical examination, all these kids every time. So here's gait analysis. So I literally, and I know Wade's looking at me going, gait analysis, that means machines and having to have 3 techs and 17 cameras. This is not how I do it in the clinic. For most of the time, I literally have them walk in the clinic in their diaper or in their underwear and just watch them. You get the sense of gross motor, you get the sense their coordination and their strength. And in this case, you can see an obvious deviation that you're going to focus on when you do the rest of your exam. Hip range of motion is very variable in children, and it's important to understand that it varies only with the laxity that they have or the disease they have, but also with their age. So normal ranges of motion are hard to really define, but about 10 degrees of extension to about 100 degrees of flexion, about 50 degrees of abduction in general, and to about 20 degrees of adduction, and about 45 or 50 of internal and external rotation standards to remember. Asymmetry is always a problem, and people that fall about a standard deviation or so away from what you would consider normal are ones that you have to pay attention to. How do you judge range of motion? So flexion extension, I like to do the flexion with the lying supine. If you stabilize the pelvis in that number B here, you can identify flexion contractures by having the pelvis stable, and then to determine if there is not enough hip extension to get to the table. But in general, this is relatively speaking here one we do. Range of motion and abduction, adduction is critical as well, and it turns out that loss of abduction is probably the most sensitive to a lot of the diseases that we deal with. These pictures, which are kind of goofy, but they're helpful, are basically showing you do an abduction, adduction with the hip and extension. As you know, often in the clinic, we will do at least abduction and flexion. And sometimes that might fool you a little bit in the sense that sometimes the hip's incongruity will be worse when the hip is extended versus when it's flexed. So if I'm any doubt, do abduction goes in flexion and extension. Internal rotation, I think, ought to be done with the children prone and their hips. And you can really measure off a goniometer if you really felt like you needed to, where their tibia is relative to a midline mark. This, again, sensitive thing. So abduction and loss of internal rotation, abduction and loss of internal rotation probably are the two most sensitive ranges to assess. I like to check strength testing two different ways. So I observe them walking, but I like to have them stand and then single leg stand. It does two things for me. One, before they single leg stand, I can judge leg lengths. And two, this judges roughly how their abductors are going. So if the abductor is weak, for example, this abductor is weak on the right side of this child's hip, their left pelvis will drop. That's called the Trendelenburg test, and it's just a generic way or a helpful way to measure weakness. And then, of course, you're going to do your manual muscle testing if you really feel like you need to isolate abductors, flexors, and hamstrings in particular. We'll get to these things. I'm going to call them provocative tests, but these are basically specific tests. DEH has a series of tests that we use. The Galeazzi is when you line the knees up, and the dislocated hip will have one knee lower than the other because the hip shifts posteriorly. It's not because the femur is shorter. Ortolani maneuver is when you take a hip that is dislocated, and with flexion and abduction, you reduce it. The sensation of reduction is called a positive Ortolani. The Barlow is when you have a hip that rests in socket, and with adduction and a posterior stress, you dislocate the hip or subluxate the hip. That's a positive Barlow. Remember, these are very sensitive tests in children about under 6 months of age, but as they get older, they can get fixed contractures, which can fool you and make you believe that the hip exam is normal. Other provocative tests include the flexion adduction internal rotation test for FAI and labral tears. And the Faber test is flexion abduction external rotation. And this can be helpful if you're assessing soft tissue injuries about the hip, SI joint complaints, pelvic pathology. So again, this is a very complicated topic. It's one that as you listen to these other speakers talk, they will all have specific things they want you to address, but these are the gross ideas and gross ways to judge physical exam. So in summary, always consider age and a broad category of disease to guide your evaluation, and the exam should be thorough and consistent. It should include range of motion that you know might vary with pathology and age, and then you should understand some of the most basic provocative tests that we use in pediatric orthopedic surgery to narrow your different diagnoses.
Great. Thanks, Marty, for that nice beginning overview and introduction on how to assess these children. So Tom McPartland from New Jersey is going to talk to us about imaging of the child's hip.
Good evening, everybody. I was on mute there for a second. Let me just see if I can move that bar from the top of my to get my slide to start playing. I know there's other ways to do that, I guess. Oh, there we go. Slideshow. So following up on Marty's presentation, outstanding presentation, Marty, on examination of the hip, imaging is a very important modality, and there's a lot of different ways in which we can image the pediatric hip. And obviously we're covering from the infantile hip all the way up to the adolescent hip in seminar. And so we'll have a brief period of time to talk about each one of these different aspects. I don't have any financial disclosures, nor do any of us. We'll talk a little bit about ultrasound, plain film imaging of the hip, CT imaging of the hip, and then using the MRI. And we'll talk a little bit about arthrogram and arthrography as well. Obviously, during the seminar, we're going to talk about a lot of these diagnoses. We're going to talk about DDH. I think Dr. Goldstein's going to do that next. And then we'll have disease and then SCFE. We're not going to talk as much about AVN, FAI, and adolescent and adult hip dysplasia, but those imaging modalities are very important, and we'll address some of those and how to interpret the images as we go along here. We'll start with ultrasound first. Ultrasound is obviously something that the human ear can't hear. Medical sounds generally fall somewhere between 10 and 15 megahertz frequency, and And the higher frequencies gives us lower depth but higher resolution. That's probably what we're using with infant hips. Lower frequency, you can get greater depth. And many of our medical ultrasound devices, we can penetrate fairly deep when we want to do a needle aspiration or use it for a procedure, but you're going to vacillate between the frequencies in order to do that. As you can see, the operator here is placing the transducer on the infant's hip, and this is a great way for us to assess the immature hip, because as you know, before the application of the femoral civic nucleus at about 6 months of age, we really are looking at a chondroid hip. And this really, the images you can see here on the right, kind of show the ilium outline up and down right here. The chondroid head does not echo the signal of the ultrasound back quite as well as the ilium does here, or the roof of the acetabulum. So we can get contrast between these different tissues, including the layering of the muscles, as you can see on the side over here. And we'll get into that in a second. Another great thing about ultrasound is that there's no radiation associated with it, so we can keep it on as long as we want. We can also push and pull on the hip, and Harkey certainly was a proponent of looking at the stability of the hip, and I think this is a really important tool for us, especially when we want to assess if you can transition someone out of a tablet harness when you're treating them for TBH. The ultrasound is probably most useful under 6 months of age. As we get older, we start to rely on plain films as our gold standard for measuring the acetabular indices and the roof of the acetabulum. It's certainly operator dependent. But the problem that sometimes happens with this is we can overdiagnose abnormalities. If you take an ultrasound of an infant in the nursery a couple days after they're born, the incidence of an abnormal finding that would suggest hip dysplasia is probably in the range of 10 to 15% if you look at the screening data from other countries. Whereas if you wait till 6 weeks of life, many of those hips normalize. The incidence of finding a positive result is probably about 3 in 1,000. There's still some false positives potentially, but far less than if you take it too early. And that's one of the biggest we have, is many kids are referred to us, they've had an ultrasound where the hip is still immature. So you always want to be on the lookout for that. This schematic is probably familiar to most of you. This kind of outlines the alpha angle and the beta angle. So the ilium is here. You can see the chondroid femoral head seated in the acetabulum. There's not much pulvinar down deep in here. The bony roof of the acetabulum. This is the hip that's more than 50% of it is underneath the ilium. So these are important parameters that we're going to look at. And if you look at this schema here, you can see where the alpha angle is the angle of the roof. We want that to be greater than 60 degrees to consider the hip normal. The beta angle is going to be a lesser degree angle, so less than 50 degrees. And that connotes what's happening with the cartilage onlogs that becomes the labrum later on. I don't use the beta angle very much in practice, but certainly the dimensions of the femoral head are within the acetabulum, and then the alpha angle as well. This graph had a schema for using ultrasound to classify how much of the hip was out of the side. Harkey looked at stress usage. You could adduct and push on the hip, and you could see that it was subluxing out. And I think this is really valuable to assess whether you're done with a Pavlik harness or not. It is really probably the best study to screen for in younger hips, but as you get older, you can still diagnose a hip effusion. This was a kid who came in the other day who was 7 years old and had an effusion that was diagnosed on ultrasound. You can see that on the right hip, it's layering a little thicker right here. On the left, it was not. The hip was not aspirated. As we get into older patients, we can use ultrasound also. You can see the needle coming in here to aspirate a joint effusion. You can even find the psoas tendon and inject it versa if you have to, if you think that's the source of your pain. So ultrasound has a lot of utilization. Plain radiography, though, is the workhorse for just about everything that we do. You know, the average American has about 3.6 millisieverts. Remember, that's a dose-related quantity. The typical adult hip X-ray is about 0.7 millisieverts. An infant is actually 1.5 millisieverts. And there's actually, as you can see in this table over here, based on age, as you come across on this line, you can tell that you get less radiation, but their risk in the future from having radiation is greater. So it's kind of lost in the sauce a little bit. But the point is that we can safely take X-rays, but obviously we want to image gently, and that's the take-home message with plain film. The available views to us are an AP pelvis, the frog lateral, the false profile view, the modified view, a von Rosen view is really useful. Dr. Schrader may talk about that. We can look at the reduction of the hip in CP sometimes and see what internal rotation does. And then an arthrogram is really valuable. The standard view is this AP pelvis. A lot of people may question if you do standing versus supine. You have to be careful with supine. You may overestimate anterior coverage and the crossover sign, which we'll get into closely. The frog pelvis is really the lateral of the proximal femur. So if you take one picture of a bone, you've never taken enough images. You want AP and lateral images, and this is your AP and lateral of the femur, okay? And so this is a way to look for tumors. This is a way to look for irregularity. We sometimes use the frog pelvis to look for abnormal offset. Obviously, there's age-related changes with maturation of the triradiate cartilage, which you can see here. Everyone's recognizing that this is a dislocated hip here on the right side, but the femorocypic nucleus is absent, and you can see where that could be missed. But there is a break in Shenton's arc. There's some really important lines here. I think the skin looks best. So the left side is the normal measure, is kind of the normal appearing hip. The right side is the dislocated hip. Obviously, I said that wrong. The left side of the image, but it's the patient hip. So the acetabular index is the pitch of the sourcil. Remember, sourcil is the French word for eyebrow, and it's the density of the acetabulum. The Shenton zone should be contiguous from the femoral neck up through the obturator foramen. Hogan-Reiner's line is our reference line upon which all these other ones are measured, and you can see that this left hip is dislocated. This is a 6-year-old hip, and I don't want to steal thunder from Dr. Kier, just to talk about Perthes disease, but you can see there's some collapse here. This is the lateral pillar classification based on 50% as our line of demarcation for when we have too much or too little collapse, and I'll let Dr. Kier talk about that more. A properly formatted AP pelvis should have the obturator foramen centered. You really should have about 2 centimeters between the sacrococcygenial junction and the pubic symphysis. And there's a lot of wonderful literature that talks about optimizing these x-rays. Here's one that's off shift, and you can see how it changes the crossover in this hip. While we're talking about the crossover is where the anterior and posterior walls overlap right here. It should be in the superior and lateral quadrants of the hip. This hip is a little bit more retroverted, and you can see that it's also got a little bit of a cam deformity right here. You can see that this is situated, this is a well-lined x-ray, but this definitely has a positive crossover. When we're looking at an AP pelvis, a lot of things we can pick up on. Sometimes when we're looking for H or impingement, we can look at impingement cyst. We can look at the prominence of a cam deformity, and we can look at it in multiple views. I think the frog view is a valuable view, but I'm a big fan of the modified Dunn view, which I'll show you in a second. For the false profile view, you rotate the body 65 degrees, and you shoot across the pelvis here. You get the beam coming across, and it gives you the anterior coverage. I do a lot of hip dysplasia work, and so this is a very important measurement to determine coverage. And you can see the measurement of anterior center edge angle and false profile. The Dunn view is traditionally positioned like this. Some people have leg holders. They do it at 90 degrees of hip flexion and 45 degrees. I kind of a little bit. So this is someone standing, the hip flexed, and this looks a lot like Captain Morgan. So in my office, we call this the Captain Morgan view. The frog view gives you kind of this offset, but the Dunn view actually shows you this a little bit better. I don't have an example of it here to show you. When you really want to assess on an AP pelvis that the hip is retroverted, there's 3 things you have to look for. You want to look for the crossover sign. You want to look for, which we see right there, we want to look at the center of the femoral head, and the posterior wall is medial to then this is retroverted, the posterior wall is a little insufficient, and then the ischial spine suggests retroversion as well. The von Rosen view, Dr. Schrader may talk about, abducted internally rotated to check femoral head coverage and see if this sucks in. I use this a lot in my neuromuscular patients. This is something that Dr. Yang may talk about later, but Klein's line is that frog view lateral. If you took an AP of this hip, you might miss the slip, but when you take the frog lateral view, so you should always order AP and frog pelvis. Don't order right hip, because you're going to get 2 views of the right hip only, and then you can't compare to the side. So that's a great principle to come home with today. The arthrogram, I think, is really valuable to verify. Infantile hip, we use it to verify inject outlines the contour femoral head. This is obviously a mature hip that we're injecting. I do a lot of my own hip injections because I can inject the sites that I want, and then I can do a dynamic assessment of impingement. CT imaging the hip. It's the best modality for bony detail, but it's about 10 to 15 millisieverts of radiation, which is a lot. The low-dose protocols get this down to 6 millisieverts. That's still a lot. So only use it when you have to. You can assess femoral version by taking cuts through the neck and the femoral neck and the knees. This is probably really useful in tumor patients to plan resections of this chondroblastoma that you see over here, to plan for allograft reconstruction of a femoral head defect, or to plan a complex acetabular reorientation, especially when they're really retroverted. 3D CTs are really valuable. I'll show you one in a second. This is a really retroverted hip. The lateral portion of the femoral, of the anterior wall, the acetabulum, supersedes the posterior wall, and this is in the most cephalite cut of the femoral head. So this is a retroverted acetabulum, and here the the AIS is probably not used because of it. This is a 3D CT that you can see right here. What you love about these is that you can get to reconstruction, then you can reprint these and make 3D models. Obviously, CT has some benefits, but it's a lot of radiation. This is a case where this patient really had a posterior insufficiency. You can see here she's got a huge hole in the posterior part of her acetabulum. She had chronic pain. No one could figure out what was going on. She'd seen a bunch of doctors. She came to me, and I couldn't figure it out for a while either, admittedly. But we found that she had this defect. You couldn't find it on plain film, but the CT showed it, and we wound up doing an antiverting TS on her, and she's been doing great since then. MR is really interesting. We could spend hours talking about it. I've already gone over my time, but it's useful to look the reduction of the head of the infant, and for perfusion and DDH and perthes and AVN. You can look for sources of FAI. Be careful of labral tears. I think there's a really high false positive read on labral tears. So when you see a report saying a labral tear, make sure you do a good physical exam like Marty was just telling you. And you maybe, when you go to arthroscopy, there's nothing there. I don't give a lot of intra-articular gadolinium. It's really not the optimal study for bony detail. If you need that, you can get CT, but honestly, it's I try to avoid CTs. I use this protocol, which is the Swiss protocol. This was published actually out of HSS, Potter series. But this adds in a bunch of different views that let you look for FAI. I would encourage you to read some more on this. Notably describe this axial view to determine the head offset, the so-called alpha angle. The radial sequence MR really helps to find irregularities and labral tears. And then sometimes you can add gadolinium in time of flight sequencing to get perfusion of the femoral head and look for this big void. And it helps to tell you where poor vascularity is. And sometimes in an infant, that'll tell me if I do something different with a close reduction. In perthes, it tells me how to classify the hip. And Harry Kim's done some great work out of Scottish Rite talking about how to use that and help determine treatment modalities. And young adult and older, I treat a lot of kids with sickle cell anemia, and it tells me where to drill the femoral head to help revascularize the hip. The Degemerich is interesting when you can look at mapping that. We've run out of time, so we can't spend too much time. But my advice is image gently. Always make sure you have adequate views, and always correlate with your physical exam. Thank you.
Great. Thanks, Tom. Lots of information in that short period of time on lots of various topics. So we'll move on to now specific conditions affecting the child and adolescent hip. And we'll go out west to Rachel Goldstein, who will talk to us about DDH.
Thank you, Josh. Let's see if I can figure out how to do this. Okay. You'd think I'd know by now since everyone has been doing so many Zooms, but I'm going to talk about infant hip dysplasia. I'm going to try to talk about infant hip dysplasia. I have no financial disclosures. My only disclosure is I really love hips a lot. So essentially, infant hip dysplasia comes into hip dysplasia comes in two flavors: infant and adolescent and young adult. We're going to focus mostly on the babies. So a normal hip at birth is deeply seated within the acetabulum, and it's held in the acetabulum by the synovial fluid. So it's extremely difficult to dislocate a normal infant hip, even at birth, even when they're ligamentous lax. Hip dysplasia represents a spectrum of pathology. So it goes all the way from dysplasia, which simply means a shallow acetabulum, on subluxation, which is an incomplete loss of the normal relationship, all the way up to dislocation, which is a complete loss of the normal relationship between acetabulum and the femoral head. And infant hip dysplasia also has types. We have typical infant hip dysplasia, which is an otherwise healthy, typically developing child. And that hip dysplasia can develop prenatally or postnatally. And there can be teratologic hip dysplasia. This is associated with neuromuscular or genetic disorders, and this typically occurs in utero. So risk factors for idiopathic infant hip dysplasia include being firstborn, because they just have as much space, females much greater than male, breech presentation, which is probably the single biggest risk factor. Left hip tends to be more commonly involved than the right hip, and that's because intrauterine positioning typically places the infant's left hip up against the spine, which leaves babies with less room to move their left hip around. And then anything that is associated with tight packaging, including torticollis, congenital knee dislocation, and metatarsus adductus, have all been associated with hip dysplasia. And then positive family history. So if you have at least one parent with hip dysplasia, you have a 12% increased risk over the general population. And if you have a parent and a sibling, you have a 36% increased risk over the general population. Now, interestingly, DDH is the most common orthopedic condition that we see in newborns. Dysplasia occurs in 1 out of 100 live births, and a true dislocation occurs in 1 out of 1,000 live births. That is a lot of babies who have this condition. Pathophysiology can be from a variety of different causes. There's some thought that this is related to maternal and fetal laxity or genetic laxity. It can be related to intrauterine positioning. So as we mentioned earlier, breech presentation. and it can be from postnatal malpositioning. So in societies where babies are born in a position with the hips extended, like you see here, DDH is much, much more commonly seen. DDH is much more common in Laplanders and Native Americans and less common in African Americans. So some of this has to do with postnatal things like baby wearing, and some of it has to do with genetic components. Now, as Marty mentioned earlier, the physical examination for babies under 3 months of age include the Barlow and Ortolani tests. So a positive Barlow test is a hip that is sitting reduced, but is able to be dislocated by adducting and gently applying a posterior force. And an Ortolani positive hip is one in which the hip is lying out of the joint, and you're able to reduce it by abduction and an anteriorly directed force. Now, as babies get older, we see things like asymmetric proximal skin folds, as you see here. So we'll often get referrals for asymmetric thigh folds. However, there is little association with DDH in distal asymmetric thigh folds, but proximally around baby's groin, labial folds, and buttock folds are highly associated with hip dislocation. You can also see limitations in hip abduction if you have a unilateral hip dislocation and a leg length discrepancy, again with a unilateral hip dislocation. When babies get up to walking age, they will start to demonstrate a pelvic obliquity if they have a leg length discrepancy. They'll demonstrate a lumbar lordosis like this baby here. They can also demonstrate a Trendelenburg type gait like you can see in this baby, or toe walking on the side that's dislocated or short. So as Tom talked about, ultrasound is extremely useful in imaging baby hips. The most useful time for this is before the ossification of the femoral head. So before about 4 months in girls and before about 6 months in boys. Although in a truly dislocated hip, ossification can be delayed. And through this, we can see the bony acetabulum, as you see here. You can see the femoral head and the labrum. You can even see ligamentum teres and the hip capsule. This picture might look familiar from the last. The alpha angle is an angle that we use pretty consistently. If you draw a line along the bony acetabulum and along the ilium, you should have greater than a 60-degree angle. Beta angle is a line drawn along the ilium and along the labrum, and you want this to be less than 55. So I always learned in residency, big beta is bad. I too don't really use the beta angle, but one thing that I do look at is I want at least 50% of the femoral head to be below the line drawn along the ilium. And that's how I know that the femoral head is reduced within the acetabulum. Now, I don't always think that hip ultrasound makes a ton of sense. However, Dr. Castaneda in New York, a really great way of superimposing these hip ultrasounds onto an X-ray, which makes it much easier to understand. So if you take your hip ultrasound and you rotate it and superimpose it onto an X-ray, you can now understand better what you're looking at with the ilium and your acetabulum. So I hope this makes a little more sense. After about 4 to 6 months of age, when you typically have ossification of the femoral head, a supine AP pelvis becomes a lot more useful. We draw a few lines on to help us better understand the X-ray. We draw a horizontal line through both triradiate cartilages, and it's called Hilgenreiner's line, H and H, Hilgenreiner's horizontal. And then we draw a perpendicular line to that cuts the edge of the acetabulum, that's Perkins' line. You want your femoral head to be sitting in the inferior medial quadrant. So even if you couldn't tell that these hips were dislocated, this head is not sitting in your inferior medial quadrant. We also look at Shenton's line, which is a line drawn along the inferior portion of your obturator onto your inferior portion of your femoral neck, and this should be a contiguous line. If this is not contiguous, then your hip is subluxed or dislocated. And then we can measure the slope of the acetabulum by drawing along the acetabulum and measuring how that relates to Hilgenreiner's line, and that will give you your acetabular index. Now, the real question is, who should get screened? How do we know which babies get ultrasounds and who should get referred to an orthopedist? So the recommendations from the American Academy of Pediatrics are that every single baby should have their hips checked at every well child visit until walking age. If they have an abnormal or questionable exam, they should either be referred for ultrasound, x-ray, or to an orthopedist for evaluation. But what about kids who have a normal hip exam, but risk factors like we talked about earlier? So the recommendations are based on these findings here. What is your absolute risk of having hip dysplasia? And you can see here that a positive family history in girl babies significantly increases risk, and breech presentation in girl babies significantly increases your risk. Now, having family history and being a boy doesn't actually increase your risk over just being born a girl without any other risk factors. And breech presentation as a boy doesn't actually increase your risk very much. So those are sort of the controversial screening guidelines. So in general, the recommendations from the American Academy of Pediatrics and the International Hip Dysplasia Institute recommend waiting until 6 weeks for reasons that Tom mentioned earlier. For a questionable exam, especially firstborn girls, for hip dysplasia with family history, girls who are breech, and then you should consider it in boys who are breech. So how do we treat hip dysplasia? For babies who present at less than 6 months of age, who have a reducible hip or who have dysplasia or subluxation and normal muscle function, we treat with a Pavlik harness. And the success rate of Pavlik harness in a typically developing baby is about 90%. Now, the way that we treat this is we will place a baby in a Pavlik harness. I see them back at 2 weeks, where I get an ultrasound in clinic in the harness, and I can see if the hip is improving. If the hip is improving, we continue with the harness. If the hip is not improving, I adjust the harness and give them 2 more weeks. Typically, I give babies about 4 weeks to start to improve in their harness. If they fail to improve in their harness over the course of the 4 weeks, then I switch them to a semi-rigid abduction brace. So my brace choice is a Rhino. However, there's a bunch of different kinds of braces that can be used. And again, I give them about 4 weeks. If the brace fails or the babies present over 6 months of age, then they go to the operating room. These babies undergo an adductor tenotomy and an arthrogram with attempted closed reduction and application of a spica cast like the one seen here. Babies who are older or who have an irreducible hip in the operating room under arthrogram, they undergo open. I generally use an anterior approach for all of my patients, although in younger babies, especially less than 18 months old, a medial approach can also be used. Now, there are bony changes that happen over time in a dislocation. That includes things like changes in femoral version, coxa-valga in some cases, and high-riding dislocations, and those things can require a femoral osteotomy. And a hip that does not have a ball reduced in the socket will develop acetabular dysplasia. So your open reduction in babies over 18 months old may require a pelvic osteotomy. Now, I just want to spend a minute talking about pelvic osteotomies. This is a really complex lecture, and if any of my residents are on here, they've heard me give an entire 30-minute lecture on pelvic osteotomies. But to quickly run through, there are 3 types of pelvic osteotomies. There are those that are reconstructive, whose goal is to restore normal hip anatomy and biomechanics. They shift the position of the existing acetabulum and use existing acetabular cartilage. And these all require fixation while the osteotomy heals. The simplest is a single nominate osteotomy, or the Salter osteotomy. We do this in babies around 18 months to 6 years of age who have deficiency in anterior lateral coverage. The triple pelvic osteotomy is for the next age group up, so about 6 years old to closed triradiates. And this can correct powerfully in 3 different planes. And then the final redirectional osteotomy is the Gons or Berenice periacetabular osteotomy. Ideally, these patients are skeletally mature with a closed triradiate. They have a congruent joint and absence of advanced secondary arthritis, good hip range of motion. This is a osteotomy involving 4 major cuts. It's a partial osteotomy of the ilium, a complete osteotomy of the pubis, and biplanar osteotomy of the ilium. So it maintains an intact posterior column. There are also reshaping osteotomies, and the goal of these is to restore your normal hip anatomy, to reshape the acetabulum. This is an incomplete osteotomy. It uses existing acetabular cartilage, and typically these do not require internal fixation because they are incomplete osteotomies. Now, these have variable names based on where you place your hinge. There's San Diego, the Degas, San Diego, all kinds of combinations of this. But the point is that moving your hinge can adjust where your coverage is. And so this is a very powerful type of osteotomy to provide coverage in a variety of different planes. And finally, the third type of osteotomy is a salvage osteotomy. We use these when the articular surface cannot be made congruent. It adds to existing acetabular stock and relies on capsular metaplasia. So complications from the treatment of hip dysplasia include osteonecrosis, and this can be caused by wide abduction or forced abduction. Typically the number that is given is about 60 degrees. Past 60 degrees of abduction can place pressure on vessels going into the femoral head and lead to AVN. Other risk factors for AVN include previous attempts at treatment, repeated surgeries. Other complications include delayed diagnosis. So that video that I showed you of a walking age child earlier, sent to me by a pediatrician whose parents were concerned that their kid was walking funny. That child had hip exams at all of his visits up until 1 year of age, and this was not picked up until he started walking. Other risks include recurrence and transient femoral nerve palsies. So femoral nerve palsies can occur from hyperflexion of the hip, either in your Pavlik harness or even seen it before in hyperflexed casts. Almost all of these recover. I've actually never seen one that did not recover, but some people consider this a failure of Pavlik harness treatment. Thank you.
Great. Outstanding. Thank you very much, Rachel. We're going to move on to the neuromuscular hip and cerebral palsy type patients with Wade Schrader out of DuPont in Delaware.
You guys hear me?
Yep, you're good.
All right, we'll get started. All right, so thanks a lot for allowing me to share with you guys tonight. It's been some great talks so far, and you know, it's hard to cover all these topics in this quick amount of time. So we're gonna get going. I don't have any financial disclosures. Let's see if we can get. There we go. Quickly, we're going to do a definition of coxa and valga, and then we're going to talk about the classic example of coxa valga in pediatric orthopedics, which is P, neuromuscular hip dysplasia. And then we'll talk a little bit about what coxa valga looks like in SMA quickly, and then finish up talking about coxa vera. So next shaft angle is one of the primary radiographic evaluations of our pediatric hip. Normal neck shaft angle varies between 120 and 135 degrees. If it's more of an acute angle from that, it's coxa vera, it's more in varus with 120 degrees or less. And if it's more in valgus, more of a steep angle, it's more like more than 135 degrees, it's considered coxa valga. Just contemporarily, we're also looking at head shaft angle for a couple of reasons as well, which is a contemporary measurement. Because the head, actually, the physis can be tilted with a relative amount of valgus relative to the neck, can have actually true capitis valgus, so that's important, especially when you're talking about the neuromuscular hip. And also the head shaft angle may be a little bit less sensitive to the rotational limb or the anteversion in terms of measurement. So it's something to think about in the context of neuromuscular hip dysplasia. CP as a definition is a static encephalopathy. It's a static lesion resulting in motor impairment. It's usually ischemic and hypoxic. Prematurity is the most common cause today. And although the neurological lesion is static, the musculoskeletal manifestations definitely change over time with growth, and we'll talk a little bit about that pathophysiology. And it's the most common childhood onset disability in the United States. And I think it's important just to start off with that everybody remember that for the most part, neuromuscular hip dysplasia is very different than DDH. And CP, most of our babies' hips are born normally. And in lay terms, the hips typically grow out of the socket. That's what I tell my family. And it's attributed to the pathophysiology of asymmetric muscle spasticity and contracture. In the combination, that alone wouldn't do it, but in the combination of lack of weight bearing, developmental delay, and then skeletal growth. And that actually leads to the bony deformity and the joint instability that we have. And specifically, we have coxavalga and increased femoral anteversion. Those specific pathophysiology aspects are the soft tissue contractures, are the adductors and gracilis, but psoas in the hip flexure is a definite issue and needs to be considered whenever you're planning treatment around the pathophysiology of CP hips. And you can't understate it that the weak abductors and extensors are a big part of this too. These are the so-called negative symptoms of cerebral palsy, of weakness. And it's a huge factor, and it's not something that we always can do a lot with as orthopedic surgeons. So it's something to think about. And then, of course, we mentioned before the bony deformity, the neck angle, and the coxavalga is the typical skeletal abnormality. And this is just a quick example that you can see a toddler that has relatively normal hips, and as a result of their CP pathology, end up with progressive hip dysplasia and subluxation. And so we're not going to get into some of the advanced radiographic techniques that was mentioned before real quickly in covering this talk. The main thing to get across is we measure subluxation with the Reimer's index, or the migration percentage. And that's the percentage of the femoral head not covered by the bony acetabulum. It's a pretty simple calculation, although it can be hard to measure with significant pelvic dysplasia, the so-called Gothic arch, and where exactly to draw the edge of the acetabulum. The error of measurement is thought to be around 5%, and the surgical indications really vary, so you have to really look carefully at that if you're looking at anything in the literature. And generally in the US, the indication is around 40%, but it can be as low as 30% in Europe. You can't talk about CP hips without talking about the gross motor functional classification system. So I'm just briefly going to show this. This was really a revolutionary method of communication for us to describe the motor disabilities for children with CP that really is helpful to communicate across specialties, where it ranges from level 1, which those kids are almost typically developed and only has problems maybe going up and down stairs, some higher motor skills, attributes, to GMFCS level 5 with kids with no head control and are completely dependent on all mobility. GMFCS is valid because it's based on GMFM. It's reliable, it's relatively stable, and the most important thing is prognostic. It predicts natural history. So in the setting of doing family-centered care and shared decision-making, it really allows us to really focus on surgical goals, and we'll get to that here briefly. Here's just a quick pictograph that shows some of the bony deformity as it relates to GMFCS level. Increased femoral anteversion is common in all kids with cerebral palsy, and it's across the GMFCS. But the migration percentage and the neck shaft angle increases as a function of GMFCS. And that is shown classically through this literature from Australia, Sue and Jason Howard and JBJS in 2006, that showed this linear relationship of increasing hip displacement as a function of GMFCS. And that was one of 3 epidemiological studies that remarkably in orthopedics had exactly all the same results, with all of these linear plots, which was really interesting, showing that migration percentage and neck shaft angle have a linear relationship to GMFCS. One thing that's really important out of these studies is it's not related, hip dysplasia and CP, not related to the movement disorder. It's not related to only kids with spasticity. So we used to think that they were most at risk, but the prevalence of hip dysplasia is the same in kids with hypotonic CP, dystonic CP, with dystonia. So it's important not to estimate those children. Hip issues usually spontaneously improves in GMFCS1 kids, but it's usually progressive, especially in those in 3 to 4, 5 function. So some of the surgical treatment, we break that down into 3 different areas of preventative or prophylactic treatment, which is soft tissue surgery, reconstructive surgery, which is VDRO and pelvic osteotomy, and salvage surgery. I'm not going to mention salvage tonight, which is resections or arthroplasty, because hopefully we're getting to these kids sooner and we don't need to do as much salvage in the future. So at DuPont, the patients for preventative hip surgery, which we're a big soft tissue surgery, is on the following the footsteps of Freeman Miller, is a progressive migration percentage more than 40% in the age 2 to 6 age range. And we're pretty aggressive in the soft tissue releases. We go after adductors, psoas, adductor brevis as needed, and gracilis. Some places also do an obturator nerve neurolysis. And the DuPont series showed some really great success for lower GMFCS levels and for relatively low migration percentages. But when you look critically at Freeman's paper, it was less successful for higher GMFCS levels and higher migration percentage, which makes sense. The Melbourne group really showed this really nicely with his Kaplan-Meier survivorship. And you know, if you really look at Freeman's paper, which kind of ended right along here, and it showed some pretty good results for kids at GMFCS 3 through 5. But if you follow them out to like 6, 7, and 8 years, you see that their survivorship goes quite low. So we really, today, we utilize it mostly very young kids, GMFCS level 4s and 5s with a high migration percentage. And we feel like it's a success if it delays bony reconstruction. So that's primarily the use today. For reconstructive surgery with osteotomies, which is a varus derotational osteotomy and usually a choice of pelvic osteotomy, as Rachel mentioned, it's a progressive migration percentage, again, more than 40%, and an older age range, really. We'll usually try to soft tissue for the younger kids, but once they get up older with more severe migration percentages, we'll go to the bony reconstruction. And the varus is what corrects the valgus neck shaft angle, so it's what corrects the coccyvalga, and the derotation corrects that increased femoral aneurysm that we talked about. For some of the results of that, the DuPont results, the classic DuPont results showed excellent results in 50 kids and 70 hips. Really only 2 hips had recurrent hip subluxation. And this was back in 1997, one of Freeman's first papers at DuPont. And even before we had really good patient-reported outcome measures, he thought it was important just to ask the parents, did they like the surgery? They think it was beneficial. And over 80% of the caretakers did. We now have CP Child, which is a health-related quality of life instrument that's specifically targeted for kids at GMFCS 4 and 5 level. If you ever look at those questions, it's important to look at that. It really talks about hygiene and how these kids dress and sit in their wheelchair. It's not quite so much as function focused. And we now know from good results from Ben Shore at Boston Children's, the hip reconstruction really improves the quality of life scores. The higher the preoperative migration percentage, the lower the CP Child scores are preoperatively. And then hip reconstruction improves those CP Child scores postoperatively. We've all quoted that the overall revision rate after VDRO and CP hips are probably somewhere between 30 and 40%. That's what Boston showed. But they were able to really dig down into the strongest predictors of surgical success, and age and ambulatory potential. Really, kids that are higher ambulation, higher GMFCS levels, and younger age had higher revision rates. But they were the first one that really showed that surgeon volume really mattered with this particular procedure, which has been shown in other areas of orthopedics. Really quickly about SMA. SMA, the prototype for advanced genetic treatments in orthopedics. Hips are typically hypotonic neuromuscular hip dysplasia with coccyvalga. So they look like a hypotonic CP hip for the most part in SMA. But, you know, I think in the recent changes in these advancements in these genetic treatments, it's really caused us to perhaps change our paradigms about survival and hip treatment and function, and maybe being updated with contemporary clinical outcomes. And this just shows hip reconstruction for relatively functioning SMA2 kid with a very similar type of hip reconstruction as CP. Finally, talking about coxavera and the pediatric hip, it's really classified by 3 different ways: congenital, which is mostly associated with congenital short femur; developmental, which is the classic type that we test and write about in the book chapter; and then acquired. It can occur secondary to fibrous dysplasia, OI, and AVN. The developmental coxavera, which is typically what we talk about, the incidence is 1 in 25,000. It's usually progressive in our very young children from 1 to age 6. It's bilateral in almost 50% of the time. We think it's a genetic basis with an autosomal dominant feature. And the characteristic feature, which is nicely shown in this x-ray, is this triangular metaphyseal fragment. And kids typically come in presenting with progressive gait abnormality with the Trendelenburg gait. How do we measure coxavera? And radiographically, where we measure it with the neck shaft angle, as we mentioned before. And then we also measure the Hilgenreiner epiphyseal angle. It normally should be around less than 25 degrees, but coxavera is usually progressive when it's more than 45 degrees. It gives us a diagnosis of that developmental coxavera up to 60 degrees. The treatments, indication for treatment, are progressive deformity with an increasing HE angle, a neck shaft angle of less than 100%, and kids that are functionally impaired by the Trendelenburg gait, and this can be treated nicely by valgus. Thank you.
Excellent. Thanks very much, Wade. We're going to move up north a little bit to Michigan and have Michelle Card talk to us about Perthes disease.
All right, great. So this should be quick. I called this the Josh Abza COVID resident teaching extravaganza. I'm on the editorial board of Journal of Pediatric Orthopedics, but I don't get any money for that. I'm going to talk about Perthes disease. So here's a radiograph, and some of the classic signs are developing, and that includes coxa plana, which is sort of a flattened head, coxa breva, and you get a sense that neck is a little shorter than the other side, and coxa magna, where the head gets big. So the things I want you to remember, I'm going to tell you right off the bat. Here are the keys to remember for Perthes disease. This is avascular necrosis of femoral head in a growing child. They typically present with a limp, and many times they don't have pain, sometimes they do. Prognosis is really influenced by the amount of deformity, the age of the patient, the amount of involvement of the femoral head, and then this lateral pillar classification, and we'll talk briefly about that. Things to remember for Perthes treatment: essentially, if they're under 6, as a rule of thumb, not really always true, but in general, that's best treated non-surgically. And if they're 6 or older, you can consider if surgery is appropriate. Overall, the goal is to minimize the deformity and decrease the risk of long-term arthritis of the hip. And we want to really be able to say at presentation who will fit from surgery. But as we'll see, we can't always tell the first time we meet the patient. So again, the definition in epidemiology, what is it? It's idiopathic avascular necrosis of the femoral head. Boys are affected 4 times more commonly than girls, and we see it in about 1 in 1,500 kids. The age of onset is described as 2 to 12, but in general, the peak is 4 to 8 years, and the etiology is really multifactorial. So there's some things. There could be something systemic, like maybe clotting disorder or some abnormality of clotting, or something we don't even know yet about clotting. It may be a genetic component, and then there's often thought to be an environmental component as well. And something similar, or we do see it in similar troubles in the hips in small stature, and a lot of times these kids are littler than most of their cohort. So to make the diagnosis, first on presentation, again, it's a painful or very commonly a painless limp. And these often little boys that are super active. And sometimes the family doesn't even catch that they're limping because they can't go down enough for a while to even look at them. They will also, on examination, often have limited range of motion of the hip, and that's typically an abduction. They'll have limitation on that side. And on an internal rotation of the hip. It may be painful, or it may just be a little irritable. And again, these are busy little guys that sometimes it's hard to keep them still long enough to really tell what's going on. You may also see a Trendelenburg sign or Trendelenburg gait. And then when we go to imaging, again, I'm going to move real quickly. Radiographs are maybe initially normal. So if you're catching this right at the phase at the beginning where there's a lot of irritability and a fair amount of limp, you may not be able to see anything on x-rays. But over time, you see increased density, the epiphysis may appear smaller, and then the stages, the radiographic stages, are these initial, then segmentation where it's broken up, reossification where it begins to be resorbed and start to heal a little bit, and then the final phase is healed or remodeling. And remember the fragmentation phase, because we'll talk about it a little bit later on. A second way to image, as Tom McPartlin talked about earlier, is MRI, and especially with perfusion MRI, you can see earlier changes than X-rays. So sometimes if you're trying to figure out what's going on with this hip and I don't see anything on X-rays, an MRI may highlight that maybe this is early perthes going on. You can see a lack of perfusion to the femoral head, and then in the old days, a bone scan, or if you were worried about tumor and you were getting a bone scan, you might see that on the bone scan as well. But here you can see the decreased perfusion, the flattening, the irregularity of the physis, and the sort of widened neck. So the Herring classification, or that lateral pillar classification. So again, we're thinking the lateral part of the femoral head, and it uses the AP radiograph. And again, this is where fragmentation comes into play. So they in the fragmentation phase, really, that's how this was tested out and written. So if you look at the very lateral side of the femoral head, if nothing is changed, it's not involved, and it is in fragmentation, that's an A. That's really the best place to be. If the lateral side has collapsed, but maybe less than 50%, they call it B. And if it's collapsed and greater than 50% collapse, that's a C. And then, so in general, the prognosis is worse if it's lateral pillar C. And then later on down the road, the Perthes study group said, ooh, maybe we should call BC together, have a sort of an in-between B and C. So I think that just highlights that, that Perthes is sort of an enigma, and it's a little bit hard to know exactly what to do. And typically, as Wade talked about with shared decision making, I start right off the bat telling families that it's really complex, and some of the greatest minds in all of pediatric orthopedics have spent whole careers trying to understand it, and that we still don't have all the answers for them. I go on to say that it's frustrating for me, but I can't even imagine how frustrating it is for those families. And to try to share can get you a lot farther with the families in a disease that we wish we had an option for to fix, and we don't really. So goals of treatment, again, are to maintain range of motion. So again, these come in with limited range of motion, and we want to really minimize the head deformity. So if we think that in theory that the acetabulum and close to normal movement within the acetabulum helps to reshape the femoral head as it heals, then keeping the head in the acetabulum and moving as close to normal range of motion as possible is really is a goal. And so if motion is limited, I always tell families it can rock allow the head to heal poorly, or allow the head to almost allow the head to extrude it as it heals. And so so that's always a goal. And then the closer the head is to spherical, the better the long-term outcomes, and that's been shown for many years. So treatment is really controversial. Again, range of motion that is can be accomplished with physical therapy plus many of these things. So all type A hips and young kids with type B hips can really benefit from some of have been shown to benefit from some of these things. So that could be Botox to the adductors, tenotomies of the adductors, plus minus Petri casts and abduction orthoses. Harry Kim has, and for many years, people have done really good results with that. I don't know if it's that Michigan kids are big and nobody wants to wear a brace or cast, but it's a super, super difficult thing to talk them into it and to get them to comply with that. Up here. So I do a lot of Botox and adductor tenotomies and working with a therapist to really, really try to get kids to keep their motion. If another type of treatment is containment. So again, we want to rely on the acetabulum to help reach the femoral head if it can. And containment, or a surgery to tuck the edge of the head up under the cup, is for lateral pillar B hips in the older kids. So that can be accomplished through a varus osteotomy, and we saw some really nice pictures of those for hip reconstructions by Dr. Schrader, or a Salter osteotomy. And so a Salter osteotomy is really nice, and my boss, Bob Hensinger, always loved Salter, I think also because Dean McEwen loved it too, and that is because is a lengthening osteotomy of the innominate. So it actually, you know, the leg essentially feels longer to the kid and is apparently longer. And so, so that shortening that happens when the proximal femoral fasciitis isn't working well is often fairly well counteracted by the Salter osteotomy. So Boss used to love that. So finally, in these lateral pillar C or very severe hips, a big surgery may not improve the outcome. However, combined osteotomies would be the way to go if that's undertaken. But poor results are frequent, just really likely related to the amount of involvement and the degree of misshapenness of the head. So outcomes are really related to, again, to femoral head involvement and often to the age at onset. And I think that the age at onset is really reflects how much time the kiddo has to remodel and recover from that. So the younger the onset, the more remodeling time, and often the better chance at a better outcome. So looking at that though, girls have a worse prognosis all in all. The extent of involvement, you have a better chance of doing well if you have under 50% involvement of the head versus greater than 50% involvement of the head. Premature physeal closure that I mentioned can result in asymmetric growth and deformity of the head and leg length inequality. So I always tell families that may happen, and we'll watch them for that, and that they may need another procedure on the road to keep them even. And then finally, this extrusion, which you see here in this picture, where the femoral head is out from under, has escaped from under the acetabulum, has a big dent in it, that is a poor prognosis. So outcomes, early arthritis is likely in kids who were older at the age of onset or had lateral pillar C involvement. And here's if you just look at the age of onset itself, there's some of the risk factors. 6 to 9 years old is about a 40% risk, and then older than 10 has about an 80% risk of early DJD. All right, so that's it. So the questions that we asked in the beginning, what age group? Again, it's 2 to 12, but really 4 to 8 is the biggest age group. They present with usually it's painless, sometimes it's painful. X-rays, if they're normal, other studies to get right now, MRI is the thing. If you look at the lateral pillar and you have 25% collapse, what class is that? That's class B. I can hear you all saying it. If you have a 9-year-old with new onset Perthes, is that a good or bad prognosis? Again, just remember that's bad. And presentation, when you meet somebody who's going to benefit from surgery, trick question, you don't always know depending on what stage it's in when you meet them. So I think that's it. Thanks a lot. Thank you. I'll turn it over.
Awesome. Thank you very much, Michelle. Great talk, as have all the talks been. So we'll conclude tonight on our last condition of the hip with Skiffy from Boston, Ben Yang. Are you on mute?
Yes. Am I not on mute now?
Perfect. We got you.
Okay. Sorry about that.
You're good, Josh. Yeah.
All right. So I'll talk today about Skiffy, and I know we're over time, so I'll try to go as fast as I can. I do have disclosures. I am a sports guy. That's one of my disclosures. So, and I would like to acknowledge Dr. Eduardo Novaes and Dr. John Cheneker, as I borrowed some of their slides for this. So what is a Skiffy? Skiffy is the posterior slippage of the femoral epiphysis relative to the neck. So what happens to the head? The head basically sort of rotates backward, and the neck becomes more anterior. So that's the key thing. The neck becomes anterior and externally rotated. So you basically create retroversion of your femur. So the femoral epiphysis slips backwards, the neck rotates anterior and external. Epidemiology, this is the most common adolescent hip problem. Males usually more common than females. This occurs in patients who are obese. There is some racial profiling in this. It does present bilaterally about 20% of the time and can become sequentially bilateral up to 50%. And as you guys already know, if you have patients that are less than 10 years old, start thinking about a hormonal disorder, either renal or thyroid. So this is for all you that are going to take the OITE at some point. This is anatomy of the physis. Although Skiffy isn't per se a problem of the physis, it does occur through the hypertrophic zone. So the rest stage is next to the epiphysis. If you have an injury there, you'll have a high risk of growth disturbance. The proliferative is of chondrocytes responsible for the longitudinal growth. It's very active. The hypertrophic area, they've already stopped dividing. There's no growth in this area, but they're getting larger. But this is the weakest part of the physis. This is where the cells sort of hypertrophy and then they die, depositing calcium and turning into bone. So this is the area of weakness, and this is where Skiffies occur. Now, one thing I want to point out is we've described Skiffy as a posterior slippage of the head and the anterior external rotation of the neck. But what I would like to do is kind of introduce maybe a slightly different concept, not necessarily different, but maybe a newer concept. And this is the tubercle theory. So if you ever look at the physis, if you ever look at the femoral head, what you'll see is that if this is the epiphysis, there's a small sort of indentation, and this indentation is located posterior superiorly, actually very close to where the vessels are, and that's called the epiphyseal tubercle. It's actually bigger in some animals, but in humans, it's relatively small. And one of the theories is that Skiffy is actually a rotation of the physis on that around the tubercle. So it's a rotation of the physis. Instead of really slipping, it actually rotates around that epiphysis, epiphyseal tubercle. So the slip is occurring by by displacement around the tubercle. This tubercle is in the posterior superior quadrant, and the tubercle actually decreases with age. So in younger kids, it's actually bigger, and that may be why you see this as the tubercle disappears, that this rotation can occur when there's less of a tubercle. Now, talking about the vasculature of the SCFE, our group has that the location of the vessels, which is in the posterior superior quadrant, is actually similar in terms of the location, but the actual number of vessels that go into this that are actually smaller. So the vasculature is less. Now, we don't know if that's a chicken or the egg. It may be because of perhaps SCFE occurring that it does kink and twist some of the vessels, which then reduces the number. Maybe a reduction in the number that causes SCFE. So we don't know what causes what, but we do know that if you're going to mess with the slip capital femoral epiphysis and try to fix things, you have to be very cognizant that the vessels are less, and so you don't want to mess with them. So how do you classify SCFE? We know that we all know this, but what I'm going to go over is the three main classification systems. We're either going to classify them by morphology, which is by either mild, moderate, or severe. We're going to we can classify them by chronicity, so either chronics occurring for more than 3 weeks, or acute, which is sort of all of a sudden. You can have an acute on chronic, and Loader's classification, which is probably the most widely used, is stable versus unstable. And his definition, he used a surrogate of being able to walk. So if you're unable to walk, you have an unstable slip. If you're able to walk, you have a stable slip. And that was very predictive of the rate of avascular necrosis. So, again, if you look at the slip, you're always cognizant of where the vessels are. So the vessels are coming in the normal. This is an acute slip where you can get kinking of the vessels. A chronic slip occurs a little slower. You're going to form this callus, and the vessels are still patent. And acute on chronic, you could again get the kinking, and that is these. Where you have the acute and the acute on chronic, where you get the kinking of the vessels, that probably is the reason for the increase in avascular necrosis. So let's go to the morphology. Let's classify them based upon morphology. So we look at the Southwick angle. That's taken on a leg lateral, and what you do is you take the anterior physis and the posterior physis, you draw a line there, and this is on the other side. You draw a perpendicular line to that, which is the blue line here. And then you draw a line that's parallel to the shaft, not the neck, but the shaft of the femur, which is this yellow line. And that angle that it makes here is your slip angle. So on the normal side, it's about 12 degrees. On the abnormal side here, it's about 40 degrees. Southwick's angle is defined as basically the abnormal minus normal, and you get 28 degrees. If you're less than 30, we consider it mild slip. If you're 30 to 50, it's a moderate slip. If it's greater than 50, it's a severe slip. Okay, so that's the Southwick angle. The Loader criteria, you either have a stable hip, so you can see callus that's formed here, and this is an unstable slip where this happens all of a sudden. And the big reason why we worry about this is the risk of osteonecrosis, which is anywhere from 25 to 50%, or actually it can be anywhere from 0 to 60%. So how do these patients? They generally present with groin pain. However, a significant portion of them will present with knee pain. So 20 to 30% of these patients will have knee pain. So I've had some of my sports colleagues who have had patients with knee pain. They thought it was something patellofemoral. They've actually done a scope, lo and behold, actually a SCFE. Don't be one of those sports guys. Always check the hip joint anytime an adolescent presents with knee pain. So patients all often present with a limp. They'll have decreased flexion and decreased internal rotation, as Marty talked about before, and they may have obligatory rotation. And now, what radiographs do you get? Tom talked about this already, but what you want is an AP pelvis. Do not an AP hip, and do not get one side of a hip. Always get a pelvis. Get a pelvis. If you don't remember anything else, just get a pelvis. Get the whole thing. You want to see both sides. You want to get an AP pelvis and bilateral frog laterals. What are the important signs? We showed you the south. You also can look at Klein's line, which is the line on the left-hand side. You should see some epiphysis here on the side, you see some of the epiphysis. This is normal. This is the Skiffy side. You can also have the metaphyseal blanch sign of Steele. This is one in which you can see Klein's line is actually normal on both sides, but because the epiphysis has rotated posteriorly, you actually see this blanching of the entire epiphysis and the metaphysis rather than these trabeculi. So that's the metaphyseal sign of Steele. One other thing that our group has looked at is looking at the peritubercle lucency. So this is sort of trying to support the fact that it's rotating around. Almost a significant proportion of the slips that happen, you can see a lucency, like even a cyst that forms right at the tubercle, and in more advanced case, and this is more advanced imaging, you can actually see cysts forming right around that tubercle, which is indicating that it's actually perhaps rotating around this area. And we actually use MRI now to look for pre-slips, and we look very much at the tubercle. So you have a slip. Let's say you fix it. What happens after a slip? Typically, what patients have is that, you know, we know from the old HSS studies and the old Iowa studies that patients with slips actually did quite well with in situ pinning. Well, you know, I think nowadays when we look at what the function is, it's probably not as good as their data suggests. You want their passive flexion less than 90, but most ADLs require greater than 90 degrees of flexion. They'll get impingement and they'll have damage to the cartilage and labrum. So, you know, when you have a Skiffy, you will have impingement. You will get femoral acetabular impingement, and that can lead to osteoarthritis, labral damage, and cartilage damage. So one thing that I do want to mention is a Skiffy is not an idiopathic cam. So I deal with a lot of I deal with a lot of slips, and I deal with a lot of idiopathic FAI. So the group out of San Diego has shown if you have a cam deformity, which is this bump right here, on this right-hand side, if you look at where the physis is, the physis actually slopes anteriorly. Whereas if you look at a slip, the physis tilts posteriorly. A slip is the opposite direction of an idiopathic cam deformity. So they're not one and the same things. So people that call a silent, you know, the epistle grip deformity a silent Skiffy, that's not a Skiffy. That's not a silent Skiffy. That is an idiopathic cam. A Skiffy is a Skiffy. And it's a posterior displacement and not this anterior displacement. So how do you treat this? We'll go over this really quickly. So if you have a mild Skiffy, so now we're talking on morphology. So if you've got a Southwick angle less than 25 degrees or so, the treatment of choice is going to be in situ pinning. Now, what you could add is you could either do a pinning with an osteoplasty. You could do this at the same time if you really want to challenge yourself. And you could do it either arthroscopically or through a little mini anterior. I actually used to do this where I used to pin them. It took us 15 minutes to do the pinning, and then we did an arthroscopy immediately afterwards, which took another hour and a half. So I took a short case and turned it into a very long one. And I'll tell you one of the reasons why, in a moment, why I don't do that anymore. So this is the technique. So you've got a right hip that has a Skiffy. What I use is I use Francis Lee's paper. He came up with all this crazy geometry and trigonometry in order to try to figure out your starting point, because I know that, you know, the residents sometimes struggle with where do I put my guide wire, where do I make my incision, how do I make this look a lot easier. If you read this article, it actually shows you it shows you what I think is the fastest, easiest way to do this. So what we do here is this line here is along the femoral shaft. This is the center of the femoral head. This line here is a perpendicular to this line. I'm sorry. This line here is along the femoral shaft. This line here is perpendicular, and this is the center of the femoral head. This is the femoral neck. So this is the angle of the femoral neck. This angle here, and if you read Lee's paper, this angle here is the Southwick angle. So if you have a Southwick angle of 0, let's say, which is normal, you're going to start your starting point here, because you're going to go straight up the neck in order to get center into the epiphysis. If you have a epiphysis that's 100% off, then you're going to start right here, and you'll go straight down to hit the center of the head. This allows you to sort of to figure out where on this line you should be and make your incision. So typically I make a small incision. I go down with the hemostat, our starting point. You know, what you want here is, this is the golden area. You want above the lesser troch, and you want to be outside of the intertrochanteric line. So here's your golden, this is where you want the starting point of your skiffy screw. You know, this is actually Eduardo Novaes' technique. He uses a bone marrow biopsy needle to kind of, because it's pretty stiff, and it allows you to get a nice starting point. I think I don't necessarily do this. I just do it with a guide wire, but this is a cool little trick that you can use. So what you want to do too is flex the hip. You don't want to also frog it. You want to frog the fluoroscopy and not the leg. If you start to frog the leg, what it will do is start to bend the guide wire. So you're going to adjust anterior and posterior, and then you're going to advance the needle trocar, and then you're going to drill. You're going to just pass the physis. You're going to reassess the lateral. You want to make sure you're about center in the epiphysis, and then you're going to place your screw. And I would beg you, put in a fully screw, please, because those of us that have to take care of this later on do not want to deal with a partially threaded screw. So in terms of the screw, we want fully threaded screw, about five threads past the physis and 5 millimeters from the subchondral bone. You'd like to be center. Again, one of the things that I'd like to try to do is avoid the tubercle. If you can avoid the tubercle, that'd be great. Again, because this is around where the vessels are coming in, and also if you go next to or just position to the tubercle, you actually have perhaps 2 points of fixation rather than one. So you can do additional work. You can take this to arthroscopy. You can actually go and resect it. This is the same patient 6 years later, where you can see a nice head neck offset that we resected. Now, prophylactic fixation, when are you going to want to do that? When the risk of contralateral skiffy is anywhere from 15 to 70%. The pros is you avoid deformity on the other side and any FAI, but the con is that it's not benign. You can have, and it may lead to a shortened femoral neck and high grade trochanter. But when would you do it? In our case, we do it when you're less than 10 years of age, if they're an endocrine reason, so they're usually less than 10, and if they're a very unreliable family. So reasons why I don't do the arthroscopy anymore is because skiffies do remodel. You can have a patient here where they have a skiffy, and this is at 1 year where you can see a sort of decreased offset, and this is them at 4 years where it looks perfect. And this patient had excellent flexion with some internal rotation. And so I usually let them get out to about a year. If they're having issues at that point, usually take out the screw, and I'll do an osteoplasty at that time if I need to. So remodeling does occur. It occurs because the physis is open. So in Europe, they don't try to kill the physis. They actually try to let it grow. And these are different constructs you can do to do that. So if you let the physis continue to grow, but you fix the head from slipping, that's another way to treat it. So in the last part of the talk, we'll be talking about moderate or severe skiffies. And what I want to differentiate is either an epiphyseal stable, it's usually a chronic one, or an acute skiffy, which is usually epiphyseal unstable. So this is a moderate skiffy. This is treated with, so you could treat them with either in situ pinning with an osteoplasty. You could do a modified done, do femoral osteotomies. You have the same choices with an epiphyseal unstable or an acute skiffy, except for the fact that you could also consider doing a reduction. So this is a moderate skiffy that was treated with in situ pinning. Lo and behold, they will have problems later on. This is a done procedure in which what you do is you do an open surgical dislocation, and you actually trim off this area of bone, which is the osteotomy portion, and you reduce this, but you preserve the reticular flap. So done properly, this is a great way to get a almost anatomic looking femoral neck. However, it's not the easiest surgery to do. You can also do femoral osteotomies. These are the osteotomies, again, the subcapital. There are neck osteotomies, the base of the neck, which is very risky, or intertrochanteric osteotomies. Those are all, they all are trying to reverse the deformity and not necessarily treating the deformity exactly, except for the done. So again, if you have residual deformity, if you do it in situ pinning, you can either do an osteoplasty or an osteotomy later on to try to improve the function. So this is a patient, and this is that same patient with a moderate SCFE, was having problems 3 years later. Dr. Navias actually took them to the operating room, did a surgical dislocation, and resected this and got their emotion and their function significantly better. This was a patient of mine that had a very large sort of severe SCFE that I did arthroscopically. I went in and removed and resected the bump. I did not correct the retroversion, but I did improve their flexion. So the last 1 minute, we'll be talking about epiphyseal unstable. So an epiphysis unstable is where you have sudden displacement of the epiphysis. You're going to get a hemarthrosis because it's essentially like a Delbay 1 femoral neck fracture. And what can happen is you'll get an increase in interarticular pressure that could tamponade, that could have a tamponade effect on the vessels. The vessels could be disrupted or disrupted. That patient's hosed. There's nothing you can do. But more often than not, it's just intact, it's just kink, stretched, or compressed. And so if release that either through a done osteotomy, which can be done, or perhaps even through a reduction, you may be able to avoid the avascular necrosis. So again, in these patients, you could just do in situ pinning, but you'll get a significant residual deformity and they have a chance of AVN. You could do in situ pinning with the reduction. They'll have less deformity, but they still have a chance of AVN, but that might be improved. You could do a modified done. They will have almost no deformity, but it's significantly more complex and they still have a chance of AVN. So in my book, with these unstable slips, a lot of times I actually will like to do a situ pinning with a reduction. So the reduction is a Ledbetter technique. You flex the hip first. You're not pulling traction. You flex it first. You internally rotate it, abduct it, which should reduce it, and you bring it back to extension. This is John Scheneker's video, which shows the reduction maneuver. So flexion, circumduction to abduction, and then pull it back down, and it's reduced. And then you're going to pin it at that point. You can, Tim Schrader has had a great article to monitor the perfusion. So theoretically, what you'd like to do is you could put a intracranial pressure monitor into the in through your screw, and you could actually monitor the pressure and see the waveforms to make sure that your head's perfused, and that will hopefully avoid the AVN risk. So conclusion, SCFE is the posterior slippage of the femoral epiphysis with anteriorization and external rotation of the neck. The treatment for mild slips is in situ pinning. You can do arthroscopy for residual deformity. For moderate, severe chronic slips, you can in situ pin with an osteoplasty later on or a modified done. If you have a acute slip, I actually will prefer to do a reduction with in situ pinning, or you can do a modified done as well. Thank you.
Outstanding. I want to thank all of our panelists again tonight for a wonderful webinar, and thank you all for your attendance. As a reminder, next week we will focus on scoliosis. I hope everyone has a good week and stays safe and stays healthy. Thanks again.